I think most of y'all know Dr. Holt. I guess the official title is Editor-in-Chief of the Southern Medical Journal. And, I refer to Southern Medical when I'm talking is that it's about Southern SMA in general. It's a Tier 1 journal. I've heard that term. Is that a proper term? Yeah. Which means that it's searchable on the ISDN networks and the things the librarians use. So like if a resident's doing research, it pops right up. And he's done lots of things. Professor Emeritus, University of Texas Health Science Center at San Antonio, clinical faculty at Brooke Army Medical Center, and currently teaching at University of Texas School of Public Health. And that's in San Antonio?
Yes.
Rich? Okay. Without further ado, Rich Holt.
Thank you, Dr. Cotter. I appreciate being here. Going to talk about an issue that I think has some concern for all of us. In fact, I doubt if there is anyone in this room right now who hasn't been touched either directly or indirectly, personally or professionally, by Alzheimer's and the other dementias. It is also arguably one of the saddest spectrum of illnesses that we deal with in the medical profession. And I don't want to be morbid about it, but there's a good chance that one or more of us in this room will eventually have some sort of cognitive disorder that can affect our lives and our family lives. I am a bioethicist, and so the thrust of this presentation today is not going to be very strongly on the treatment of Alzheimer's and so forth, but rather the ethical issues that are associated with these with this spectrum of diseases. What's the reality? Well, we know that it's estimated well over 5 million Americans are currently living with Alzheimer's disease. It is the 6th leading cause of death in the U.S. And over the next course of 3 decades or so, this disease is liable to triple in number. It is fatal, and the persons in the advanced stages are considered terminally ill. And the fact that they are considered terminally ill has a good deal of importance in making end-of-life decisions, and the care of futility in these individuals, as we all know, is important. It's one of a broader spectrum of dementias that really describes the general process of loss of memory and other mental abilities and capabilities that affect day-to-day living and interactions with other individuals. And pathophysiology is known in part, but essentially it's very disruptive to the brain and the brain functions itself, and may well be the most costly set of disorders in the U.S., especially when you consider that the individuals also have the typical morbidities of aging, because most of the disorders are late onset in senior Americans. We can start talking about this by looking at the mild cognitive impairment, or MCI. It's sort of midway on the spectrum between sort of normal aging and the worst of the dementias themselves. What it involves is a sort of a noticeable decline in cognitive abilities, particularly in memory and more complex thinking skills. Now, a person with MCI is at increased risk of developing Alzheimer's or other dementias, but it doesn't necessarily mean that they will go on to develop a worsening form of this. And the cognitive changes that are serious enough to be noticed may not interfere with life or the functions of that particular individual on an independent daily basis. It can be described based on the thinking skills that are affected. Amnestic MCI primarily affects the memory. That is, when do I have my doctor's appointment? Oh, I don't remember talking to you about that, or perhaps maybe in a set of conversations, the person will mention the same thing over a number of times, and they may not recall recent events that occurred. The non-amnestic affects the skills really other than memory, and that involves a more complex series of cognitive thinking that has to do with setting up a project or carrying out or thinking out the steps of a particular project, or maybe visual perception issues. They see something, but they don't really recall what it is and can't recall the name for what that is. Currently, there are no really specific tests for the mild cognitive impairment, and the diagnosis is based primarily on a comprehensive evaluation and sort of a gestalt of what's going on and following of the patient over time. No particular FDA-approved medications. Coping strategies are pretty much the same as our normal aging strategies. Regular exercise, particularly blood flow cardiovascular, because there is some association perhaps with cerebral cardiovascular flow, and participating in mentally stimulating and socially engaging activities. Dancing, crossword puzzles, engaging conversations, and so forth are very helpful. Attending meetings like this as well. And so the physicians who care for these patients, and most of them are cared for by primary care, internal medicine, and some geriatricians, but also family medicine, are evaluated over a period of time to sort of get a feel for what progression might be, or it may be a stable disorder. So here's a list of all the dementias, Alzheimer's being the most common, and of Alzheimer's, the late onset, more common than the early onset. Vascular, to which most of us, or many of us, might be susceptible because of lifestyle and heredity, come in at about 10%, and then the others are very mixed. Parkinson's disease is considered dementia, although not all patients with Parkinson's tend to develop a dementia over time. So for any given dementia, what can one do? Well, you probably know more than I do if you're seeing these patients quite regularly. But the physical examination, as it should be, is foundational to the evaluation of these patients. Psychometric testing, the mini mental state exam, and the geriatric depression scale are often used by individuals. Some do a neuropsychiatric exam, either in the office or upon referral to a neuropsychiatrist. Some might be one form of neuroimaging if there is a high index of suspicion. There are CSF biomarkers. Amyloid imaging is a possibility, and then a really good evaluation of the skills of daily living. And oftentimes it requires the participation of the family members in the evaluation process, because they'll know oftentimes more than the patient does about how that individual is doing with skills of daily living. Now, the mini mental state examination is an interesting thing. I recently downloaded it on my iPhone, and I'm going to ask my wife, who's a physician, to give it to me about every 3 or 4 months to see how I'm faring. You can either give the patient the original or a second edition version. It's on the iPad, and it's usually compatible with your EHR, so you can record very easily the results in your electronic health record for comparison. So you conduct the examination. It gives you the questions to ask. It can also utilize the camera on your smart device for either identifying drawing and writing tasks for the patient that will be graded, or you might even be able to use a little video to tell how the patient is doing in their thought process. And then there's a scoring sheet that you will end up with. The examination is very inexpensive. You sort of buy it online, and you get 5 exams for $7, which is very inexpensive, and you just use it on your particular smart device. I think it's probably a good part of armamentarium for individuals who utilize these broad examinations for identifying cognitive dysfunction. Now, the issue of genetic testing is probably one of the most difficult ethical questions that come about in these particular illnesses. There are a lot of genes that currently are suspected to confer greater susceptibility for developing the late onset Alzheimer's. The most prominent being the APOE4 gene, which encodes the protein lipoprotein E. An individual has one copy of that particular gene may have a 3-fold risk of developing Alzheimer's disease. But it doesn't necessarily mean that they will develop Alzheimer's, quite honestly. So the ethical issues that come up are as follows. It really has no particular significant reliability for a given patient. It's more of a population-based evaluation. It just gives general information, but not particularly on any given patient whether or not they will or won't develop it. If someone knew that they had the gene, it might cause unnecessary anxiety in them and in their family members. And in fact, one of my colleagues whose mother and grandmother had Alzheimer's disease recently asked me if he should take this test. He's a physician. And I just simply asked him, would you change your life at all if you knew you had the gene? And he really thought about it, and he said, well, the only thing is I'd worry more about it. And so there has to be some real good reason why an individual might elect to have this test. It can be done. There's no doubt about it. And exceptions for your recommendation might be for the rare early onset cases where younger members might be facing a hereditary early onset of Alzheimer's disease. But it is an individual decision. And it's important if someone comes to you with this question that you really have the time or take the time to sit down and explain to them not only the benefits of knowing, but certainly the risks of knowing and what that balance might be in their particular life. Other issues of concern with any kind of genetic testing, quite honestly, is that there might be unwarranted disrespect for the patient from others if they found out that they were going to develop it. They might discount that person over a period of time. There might be social consequences for it as well if others found out. And particularly insurance companies, if they had access to electronic health records, which they do when they do audits, and found out that this individual had taken a test and was potentially susceptible to developing this, that might give rise to their concern that might be acted upon unfavorably with their insurance policy. And it's important that if you are in a position to counsel individuals about this, that it be done in a culturally and linguistically appropriate format at their literacy level, which varies, of course, across your whole patient population. Some individuals will understand the ethical and other considerations more than others might. And certainly in some cultures, they do not wish for older folks, let's say in their family, to know bad news about themselves because it would cause them undue anxiety, and they try to protect them from that type of anxiety. Now, on the other hand, I think there are ethical reasons that compel us to want to disclose information if we do believe somebody does have Alzheimer's or another dementia. And the primary reason for disclosing this to a patient early on is that they have time to make decisions about their future and their health care. That would include contingency planning on their short-term and long-term health care, and to plot a course with their family or interested individuals in their life that give them the best opportunity to enjoy life as they would see they wished to do. It also provides them with the knowledge that they should have advanced directives to physicians, and that they would appoint a durable medical power of attorney who usually is also their surrogate decision maker. In some states, such as Texas, there's a very well-defined list of surrogate individuals according to their relationship to the patient, and that can be used, but it's always better for the patient to have a durable medical power of attorney vested in some individual who knows them well enough and who has discussed their life's wishes with them to make those decisions at the time that is particularly necessary. And financial decisions are certainly among those that have to be considered over time. And also, there may be an opportunity for the individual after disclosure to think about whether they would like to participate in a therapeutic trial at some point in the future. If they're able to give that directive and to give consent while they're still competent, then the surrogate decision maker would use that and allow that person to be in a therapeutic study that might occur after their competency has dwindled. Disclosure of progress should be ongoing, so that once the patient has been diagnosed, understand the diagnosis and the implications for their life, a very close follow-up and in the introduction of the proper timing for some of their decisions can be made. It's a difficult problem, and those of you who have taken part in it, in family member or even in your patients, know how difficult these things are for everybody who's involved in it. And when these disclosures are made, they must be made very honestly. Most patients, I think, want to know where they stand. Just like if a patient has cancer, most patients want to know what does it mean for them in their life, and you are the individuals who can help them with that. And this is where the science and the art of medicine comes in dealing with these individuals. Compassion and empathy are just as important as the intellectual information that one gives to a patient and the family at this particular time. And it's important particularly for the primary care doctors, the neurologists, and those who deal quite frequently with these dementias, that the patient and family knows the physician or the other healthcare provider will be taking the journey with them. And that's very comforting to those individuals. On the other hand, the wishes of the patient really in the United States carry primacy. Why is that? It's not the case in many countries, in most countries outside of the United States, but I think the U.S. was founded on the premise of individual rights, and so autonomy really is very important to us here in the U.S., as well as beneficence, non-maleficence, and social justice. In order to have autonomous decision-making by patients with these dementias, they have to be judged competent. And that's a legal term that they're able to give informed consent or decline informed consent for therapeutic measures that are offered or decisions are made. The problem with some of these diseases is that the patient may be competent one day and incompetent the next day. So there's a real flux of this possibility. That's why it's very important to have a surrogate or a durable medical power of attorney for somebody who can oversee these periods of time. And individuals may be competent for medical decisions, but not financial decisions or these other things. And the diagnosis alone is not a sign or an indication of incompetence for medical decision-making at the time. So if they're competent, they do have a moral and a legal right to accept or reject medical recommendations. The surrogacy for these individuals is a tough position. If any of you have ever been in that position where you are making decisions for a loved one who has a dementia, you know how difficult it is. And these disorders are, as I mentioned early on, very sad disorders. Oftentimes they lose their identity in the eyes of those around them, because they have a disconnect with the rest of us. And so making those decisions is a great burden for a family and for the surrogate decision makers. Also, those individuals should not be automatically rejected for surgical procedures for acute life-threatening disorders, and I'll mention that just a little bit more. And there are cultural and ethnic issues in patient autonomy. I travel and teach and operate in a good number of countries around the world, and I know that in some of those countries, some autonomy is placed in the hands of other individuals, even though patients are competent. And so you do have to have a sense of the culture of that family, of that group, and the patient. And if you don't understand it, be sure to ask, and I'm sure they will explain it to you what the context of their culture is in this particular setting. There is hope for, if not improvement, stabilization in at some level, particularly in some of the early dementias and the mild cognitive impairment problems. And this really involves a cognitive stimulation, and it may actually help some or sustain their capability over a period of time for cognitive functioning in their daily life. This therapy, as well as some drug therapy off and on, may also help and be symbiotic. Memory clinics, you've probably seen on TV ads for different types of programs that help individuals, computer-based, that help stimulate some of their cognitive capabilities. And then specific memory exercises that focus on the patient's important safety issues, that is, their memorization of a phone number or an address or the name of somebody to call if they're found wandering about would be very helpful. And these sorts of activities can also involve the caregivers and give them a sense of participation in this whole process. And they're most effective in the early stages of the dementia themselves. We consider in the ethics community these individuals to be vulnerable patients, just like pediatric patients. There aren't that many drugs that help with symptoms. Their efficacy is considered to be modest. Patient selection's very important. Some of these have risks that may outweigh the benefits in a given individual. And the patients and family need to know they're certainly not curative and likely not to even be preventable. It's also known ethically that if an individual with the dementia is in a clinical trial, they should not be on a placebo if that's the arm that they're assigned to for more than 3 months. It's just not felt to be appropriate. There's a good study came out of Finland just recently that showed that antipsychotics are often abused or misused in these patients, and they should just be used for short-term therapies. Now, how about a little bit more on emergency care of these individuals? And if they're not terminally ill or in hospice care, or for whom acute medical or surgical treatment would be considered futile and inappropriate, it is both ethical and humane to provide both of these. And if a dementia patient has a do not resuscitate directive to physicians, but is not in one of those categories of futility, discussions should be held with the surrogate to consider some sort of medical or surgical intervention for an acute problem. And the DNR can actually be temporarily suspended when they go to the operating room and then reattached to them and reordered at an appropriate time a little bit later. And what would this be? Well, something like acute appendicitis in an older individual, traumatic injuries. I see these folks who fall and they come in, they have temporal bone hematomas, they have nasal jaw fractures, lacerations on their face and head. Those are things that we should do for them because they're very painful and they're of an acute nature. Perhaps a parotid abscess or a neck abscess that can be handled appropriately falls into this category as well. The advanced stages of dementia really are what lead to the patient's passing, and you're probably very familiar with these. The recommendations now, particularly in the ethical community, is that hospitalization is not recommended. Comfort care should be given, and that this should be given in a setting of either the hospice, setting in their home with appropriate attendants that are hospice trained or knowledgeable, and that they be cared for in a very humane and empathetic manner. Patients should develop the directives to physicians, which give their primary care or hospice or palliative care physician the knowledge and background about how they would like to be cared for at the very end of these. And this may include no aggressive treatment save for pain management and comfort care, and that during this whole process, the patient should be considered a person worthy of all empathy and compassion. There is a tendency, I think, with the individuals who have this illness to lose some of their human identity. They don't have a memory. They don't particularly remember who they are or who they're with, who their family is. And that can almost make individuals feel that they're kind of a blank slate, but they're not. They are the person that they were before. It's just that this has occurred at the end of their life, and they don't have the memory that they should. And the empathy is so very important. Unfortunately, there are some nursing homes, some areas where the attendants aren't very kind to these individuals, and as the physician caring for them, you certainly want to be on the lookout for that, because they warrant all the humane respect and care that anybody does. There's a very good site that we actually developed from our Ethics and Humanities Center in San Antonio. It's called texaslivingwill.org. It simply is a great way for people to go online and to fill out their directive to physicians online, print it out, sign it, and there it is. I think it's as good as anything that you can find, and it's very easy for somebody to help an older individual work through this process. And at the same time, they're talking to the person afflicted with this disorder about their wishes. And I think it's important to explain this to the family or the caregivers. Now, the other issue is the caregivers themselves need a lot of support. I'm sure you know that this is a very, very difficult task, taking care of these folks. And most individuals simply cannot take care of somebody, don't have the money. Are we being invaded? Yeah, okay. Well, I hope they're lower ranked than I am. Many people cannot afford the more sophisticated dementia living facilities, and so they have to take care of their individuals at home or themselves. It's a 24/7 task for a lot of people, and particularly for a spouse doing this. It's just a really very serious thing. Burnout of family members is very common, and you have to be on the lookout for that. And I think being a physician or a nurse, you have the ability to sense that in the family members when you evaluate them and see them and care for them and talk to them and so forth. It's very emotionally demanding, and there aren't that many resources available to help the family or the caregivers at this time, unless they're in a facility themselves. It's very lonely, it's very demanding, emotionally distraught, and it's important that we as healthcare providers understand and empathize with the caregivers as well as with the patient themselves. There are some resources as far as their ability to read about the issue and so forth, and what I'd recommend is that the families go to a bookstore or go on Amazon or go to a public library and look for some of these caregiver support books that they can read, and it helps them to know that there are lots of other people who are in this particular thing. It gives them some information about how to cope, where to go for some help, and so forth. I particularly think the 36-hour day is a very important one that caregivers can read as well. So here are some references. I can certainly share them with you if you want. But overall message, I think, is these are among the most difficult disorders to deal with. The healthcare provider, the patient, the caregivers, anyone associated with these diseases feels it emotionally in some particular way. So I'd like to just now throw it out to all of you. Questions if you have them, but primarily if you have comments or experiences that you'd like to share with the group that also would complement what I've presented right now. Dr. King.
Yeah, come on up to the microphone if you would. And remember, we're doing a live webcast, and those that are looking in can hear better if we use that microphone. Go ahead.
Hi, Dr. Holt.
Hi, Dr. King.
Presentation. I've heard on the radio seems like it has something to do with fibrillary tangles or neurotransmitter deficiencies or tissue generation. So how can doing crossword puzzles, keep it from happening?
Thank you, Dr. King. I think you're exactly right. It really can't. It's not preventative, it's not curative, but probably like any of the, any memory disorders, there is a possibility that you can reroute, reconnect some, or make some new neural connections, or in fact focus on certain things that might be helpful to others. I know that when you look at the worst case, an individual who sits at home, doesn't be stimulated by anybody, tends to have a more prominent downward course. Individuals who are interacting, they're doing things, they're keeping stimulated, seem to have a less progressive course. And I don't know the neural physiology completely of that process, but I think it's the stimulation, the keeping the brain a little plastic, a little active, may indeed cause some new interneurons to be developed, some new pathways, and it might help them slow the course of the progress.
Keep in contact with a lady who was doing psychological evaluations for trauma patients, for concussions, and for people with dementia from Springfield, Mass. And she sent me a very interesting observation that she found in all of her dementia patients, if she did nighttime oximetry, a simple test that can be done by an oxygen company in the home, doesn't require fancy equipment, that more than 70% of the people with dementia were hypoxic at night. And she did two things. One, she gave them one group plain simple oxygen. She had a control group that had dementia. She actually had a more sensitive scale than the one more commonly used. But what she showed was that in the people that had the usual dementia, there was a pretty predictable curve of doing worse. In the people that were hypoxic, when she corrected the hypoxia, it slowed the process down substantially. But most impressively, that they use CPAP at night, which is the pulsing of oxygen. There was a very dramatic slowing, and in some cases a total reversal of what had been advanced dementia. And I haven't seen this published yet, but she really got me fascinated with the fact that there actually is a remedy which does not require drug side effects, etc., simply using something very simple. And I don't know whether it's worth incorporating in your program or not, but certainly in any of the dementia studies, a simple test like this, which has great benefits in terms of extending the time of competence, seems to be a real good idea. And I don't know whether you ever ran into it or not, but I had never seen it, never heard of it, never seen it published. She did send me some data, which I'll dig up and send back to you when I get back to St. Petersburg, about what she found in the process. But it's fascinating to me, something this simple would actually make a difference in a disease that we all have no handle for.
Very interesting. Thank you for sharing.
So you mentioned the mini-mental status exam, which we can buy copies of. I was curious if you've had any interaction with the MOCA, the Montreal Cognitive Assessment, and if you have, what your opinion is on it, since it's the free counterpart.
I have not. I've got to, in fairness of disclosure, I'm not primary care, I'm not psychiatry. I deal with the patients on from the ethical standpoint. So I don't know about that particular test. This one intrigued me because it was a smart device capable, and it was very interesting. It was portable. It could be done anywhere, bedside, hospital consultation, or what have you. Do you have any information about the Montreal that you?
Well, I know there were a few studies when it first came out that had it equal to or exceeding the sensitivity and specificity of the mini-mental status. I taught my MA to do it. It took me 5 minutes. Basically, I administered the test to her so that she'd see how you did it. It's fairly easy to do in an office setting, one sheet of paper that you hand your patient. And it's pretty similar. It's,
Yeah.
you know, the Gorilla clock's still on there, naming object's still on there, 5-minute recall's still on there, so it's, I think it's worth looking into if you are going into your offices, because
Good.
a lot of offices are using the mini-mental status and just not paying for it. I've told partners before, I've said, you know, you actually have to pay to use that. Most people don't know that. They'll find it out later if they ever get audited.
Yeah.
But it's something worth looking into.
Okay, thank you for sharing.
It's the MOCA, Montreal Cognitive Assessment, MOCA. You can pull it up online for free, print it off. Has a detailed instruction, you basically read through it to your patient.
Thank you.
As the population continues to advance, we're seeing more patients coming for total joint, spine procedures with Alzheimer's disease or other cognitive disorders. If we're treating for pain, I can see it. If we're just treating for arthritic conditions where they're able to ambulate, how do you feel about this ethically?
Well, thank you. You brought up an excellent point, and that is where in the elective process of surgical procedures is it helpful? For instance, you talked about some of the orthopedic problems. My wife is an ophthalmologist. Doing cataract surgery on an Alzheimer's patient or another dementia patient, is that ethical when they no longer read? Yes, it probably is, because they have mobility issues. If they can't see well, they're more likely to fall and injure themselves. I could see with some of the musculoskeletal issues, if they would make the patient much more prone to developing something that would increase their risk for falls, it could certainly be considered ethical to help them in that particular regard. But if it's something to try to get that you normally would do for somebody to get them back in a sports activity or exercise training or something, that probably isn't necessarily helpful, unless they're in the early stages and you have felt that cardiovascular and other strength exercising would be helpful to their general health and their vascular tone and so forth, then it might be considered. It's probably one that has to be individualized for every patient, and given their particular situation and what they would like to accomplish. The farther they get into the extremes of the disease, it's less likely that elective procedures would be ethically considered. Thank you for the question.
Go ahead. Yeah, come on up to the microphone.
I just wonder if you could comment on the evidence that cardiovascular exercise helps reduce the progression of dementia. Are you familiar with some of the studies discussing that? There are a lot of things that are very positive.
I am not extensively informed to all of these studies. The gestalt that I have is, like most things in general health as we age, anything that that helps vascular tone, vascular flow, musculoskeletal stability are all very helpful. And the risk factors of sedentary patients, I think, generally held to be higher than active people. And so, common sense would say if you maintain a fairly strong level of activity, you're probably going to have better blood flow, you may have better diet, you may have more cerebral vascular flow, and I think a number of studies have indicated that. I can't cite them to you offhand, but I think overall it's a generally held concept that that brain function can be diminished by certainly cardiovascular disease that might be affected positively through exercise and diet and so forth.
Rich, thank you for an excellent, insightful presentation. Let's give him a hand.